pagi semuanya. Selamat datang dan selamat bergabung dalam seminar Rabuan kali ini. Saya Vika Oktaria, saya akan memoderatori sesi kali ini. Pada kesempatan ini kita akan bahas topik yang sangat menarik terkait dengan adolescent mental health in Indonesia, current state challenge and opportunity. Seperti kita ketahui bahwa adolescent atau remaja itu dapat didefinisikan sebagai individu dalam rentang umur antara 10 sampai dengan 19 tahun, di mana ini adalah suatu masa transisi antara dari anak-anak kemudian menjadi dewasa. Dan pada saat ini, pada usia ini terjadi perkembangan dan perkembangan yang sangat pesat, baik secara fisik, kognitif maupun psikososial. Dan yang menjadi tantangan dalam sebagai remaja adalah kemampuan remaja dalam melakukan perencanaan, pengendalian emosi, dan juga pengambilan keputusan. Kadang kemampuan tersebut perkembangannya lebih lambat dibandingkan dengan kemauannya untuk mencari kesenangan dan sebagainya. Sehingga ini membuat perasaan, pikiran, dan pengambilan keputusan serta interaksi di dunianya sangat dipengaruhi oleh dunia di sekitarnya. Sehingga menjadikan mereka menjadi rentang terhadap adanya gangguan mental. Dan pada kesempatan ini kita memiliki dua narasumber yang hebat yang akan hadir bersama kita hari ini. Pembicara tamu kita yaitu Dr. Holly Eskin dari University of Queensland. Good afternoon, Dr. Eskin. Thank you very much for joining us today, and we will be very keen to hear your talk today. Dan satu lagi ada pembicara kita yang sudah tidak asing, mungkin bagi kita semua ya, ada Dr. Amirah Wadi. Dr. Amirah ini sudah banyak berkecimpung di dunia kesehatan remaja, dan nanti akan berbagi cerita tentang penelitian yang sudah dilakukan terkait dengan kesehatan mental remaja. Dan sebelum sesi ini saya mulai, saya akan menginformasikan bahwa nanti akan ada sesi tanya jawab yang akan kita lakukan di akhir sesi. Nanti dapat dilakukan, para peserta dapat melakukan pertanyaan langsung, menanyakan langsung maupun menuliskan pertanyaan dalam bahasa Inggris maupun bahasa Indonesia dalam kolom chat. Nanti kami bisa bantu menerjemahkan apabila akan disampaikan ke Dr. Eskin. Kemudian mohon peserta dapat tertib untuk matikan mikrofon selama berlangsung. Dan saya rasa mari kita mulai. Saya izin share dulu untuk memperkenalkan pembicara kita kali ini. Izinkan saya menggunakan bahasa Inggris. For the first speaker, we will have Dr. Holly Eskin from the Queensland Center for Mental Health Research. Her current position is a researcher or consultant within the Queensland Center for Mental Health Research in Australia, and she's also affiliate associate professor of mental health metric science in the University of Washington, USA, and she also honorary fellow from Murdoch Children's Research Institute. She graduated the bachelor in psychological science from University of Queensland, and she completed the Doctor of Philosophy from School of Public Health, Faculty of Medicine and Biomedical Science, the University of Queensland. And she has a very extensive research experience in around child and mental health in adolescent. So without further ado, I would like to introduce Dr. Holly Eskin. Time is yours for your presentations. Thank you.
Thank you very much for that introduction. I will just share my screen. Hopefully everybody can see that. Wonderful. So as mentioned, my name is Dr. Holly Eskin. I'm from the Queensland Centre for Mental Health Research and also affiliated with the School of Public Health at the University of Queensland in Brisbane. My association, or my team's association through UGM, comes from a project that Dr. Amirah Wadi will be speaking about, which is the Indonesia National Adolescent Mental Health Survey. And that project is being conducted with several organisations, UGM and UQ being two of them, also Johns Hopkins University and two organisations in Vietnam and Kenya. So what I'm going to be focusing on today is really adolescent mental health from the public health perspective. And we can't look at that without having a good sense of what are we actually talking about or who are we actually talking about when we talk about adolescence? So what is adolescence? At its core, it's a critical period of development and transition from childhood to adulthood. And it's marked by not just change, but very rapid change in terms of physical development, cognitive development, and also social and emotional development as well. Now, the standard WHO definition of adolescence is 10 to 19 years, but there is often a lot of variation in definition across countries, across organizations, and across fields. So the definition can vary from, let's say, 10 to 17, because often in many countries, 18-year-olds are considered to be adults. Often as well, many lay people, so people not necessarily in a health research field, view adolescence as the teenage years, so 13 to 17 years. Just to add further complication to this as well, even WHO will often look at the whole youth group, which is adolescents and young adults are combined, which goes from 10 to 24 years. So when we're speaking about adolescence, in your previous work or your previous research or just your everyday life, you may have heard adolescence being referred to across a range of different ages. So I guess just to create a foundation that for the talk today, we're going to be mainly focusing on the WHO definition, which is 10 to 19 years, with a little bit of a focus on the 10 to 17-year group as well. Now, adolescence is obviously very closely related to childhood and youth, but really it sits between those and it's recognized as distinct from childhood by both researchers and policymakers. So WHO has recognized this in many of their recent reports and global strategies, where it is now maternal, child, and adolescent health that's now being considered. So what is adolescence? What actually makes it unique? Well, the graph on the right-hand side here, I guess, shows you the changing influences. So what influences someone's life once they hit adolescence? So it's this growth of influences from beyond the family. So we know that in childhood, an individual is very influenced by their family, they're very guided by their family. But adolescence is the age where I guess young people start to break away or pull away from their family a bit and become more influenced by both their peers and also media as well. There's an identity formation, so that greater sense of self, that unique sense of self, and the development of new interests, which aligning with the onset of puberty also relates to interest in sexual and romantic relationships. Now, there's a biological base of adolescence in terms of the actual brain anatomy. So the prefrontal cortex, which is responsible for that planning and that emotion control and that impulse control, actually develops later than the limbic system, which is responsible for processing rewards and pleasure-seeking behaviors. And one of the best examples I've heard of how to describe this in adolescence was it's like having the engine of a Ferrari and the brakes of a VW Beetle. That's essentially what's going on in adolescents' brains. So we're talking about a really unique kind of individual compared to childhood and young adulthood. Now, today's generation of adolescents specifically are very much being influenced by unprecedented global change. So just thinking about when yourselves were in high school versus what high school is like now, the advent of technology and how much that has become part of our lives, particularly in terms of social media, and knowing that adolescents are becoming more influenced by their peers than their family as part of their normal growth. The advent of social media and the pervasion of social media throughout all aspects of life has really been, I guess, a major change in adolescence compared to previous generations. Of course, we have to mention as well COVID-19. So these adolescents are growing up during a period of not just transition for themselves, but amongst global uncertainty and global change as well. Now, if we look at 10 to 19 years, 16% of the global population are adolescents. So thinking about those things that I've just described, 16% of the global population are undergoing these changes at the moment. In Indonesia, that has a slightly younger population, it's around 17%. And this generation of adolescents has been identified as the golden generation. I do have the Bahasa translation up there, but I will not try to pronounce it because I'll do a terrible job. But the golden generation has been identified as crucial for Indonesia's future economic growth. So keep that in mind as we go through some of these things. So why is mental health specifically important to adolescents? Well, adolescence is a critical period for mental health because poor mental health in adolescence can have significant impacts both now and in the future. And these impacts can kind of compound on one another. So if your education during adolescence is impacted by being unwell, by having poor mental health or a mental disorder, that's then going to start impacting you later in life as well, around your ability to get a job or find your life partner or so on. So nothing, I guess, happens in isolation. And we need to think about the impact of poor mental health on adolescents, both now and in the future. And when we think about, well, how would we try to improve adolescent mental health or what may be driving some poor mental health? We know that adolescent mental health is influenced by a number of different risk factors. So let's say bullying, substance use, poor self-esteem, and so on. But there are also protective factors as well. So good family functioning, positive peer networks, and so on. There are also other factors at play as well that can be both protective or risk. So thinking about service use, the ability to access services or an awareness of where to access services can have a big impact on mental health as well. And there's just a quote that I do like to put at the bottom of this is that there is no health without mental health, and that applies to all ages, not just adolescents. So now I'd just like to touch on mental disorders specifically. So mental health is a spectrum. In its simplest form, it's a spectrum of poor mental health through to positive or good mental health. Now, a mental disorder is down the poor mental health end of that spectrum, and it's a clinically significant behavioral or psychological syndrome or pattern that occurs in an individual and is associated with distress, disability, and significantly increased risk of suffering death, pain, disability, or an important loss of freedom. Now, a mental health problem is similar to a mental disorder because it interferes, obviously, with how they think, feel, or behave, but to a lesser extent than a mental disorder. So as I go through these discussions, what I'll be focusing on is mental disorders. So for those of you working in the health field, we're talking about those that reach the clinical threshold for diagnosis. Now, how we define mental disorders, and this is coming from a global health perspective, that one of the main diagnostic criteria is the Diagnostic and Statistical Manual of Mental Disorders. We are currently up to the 5th edition as of 2013, which is the DSM-5. So this is based, or it's developed by the American Psychiatric Association. And we have to have manuals such as this because unlike infectious diseases, where a simple blood test can tell us is someone ill or not, with mental disorders, we don't have such a simple approach. So we have to develop not just symptoms, but also criteria around those symptoms as well. So a certain number of symptoms are required. A certain duration of these symptoms are required in order to be diagnosed with a mental disorder. Now, I will note that DSM, considering that we're up to 5, has gone through a number of iterations over the years. And towards the end of my talk, I'll mention why that, I guess is problematic when we're trying to look at trends across time. I'll also mention the ICD-10, which is developed by the WHO. That's another way of, defining mental disorders. But for the purpose of this talk, I'll be mainly focusing on DSM-5. So there are many different mental disorders. So I just have that short sort of higher list there in the middle, but there are 157 individual mental disorders in the DSM-5. And each disorder is described in terms of its symptoms. There are set criteria that I mentioned before for each of these disorders. There are also some risk factors that are identified. Culture and gender-related features are noted as well. And there are also what we call specifiers, because we know even within the same disorder, there can be slightly different presentations. So for example, with ADHD or attention deficit hyperactivity disorder, there are 3 recognized subtypes. So the hyperactive subtype, the inattentive subtype, or the combined subtype, where they show symptoms of both hyperactivity and impulsivity. So I guess just to give you an overview, for those of you who aren't familiar with how we define mental disorders, that there is a structured and widely accepted method of doing this, but there are still, complications and complexities with this as well. So some examples of mental disorders in adolescence. You'll be glad to know that I'm not going to go through the 157 disorders one by one. So I've just picked out some of the most common mental disorders in adolescence, and this will also relate to some of the research that Amira will discuss later as well. But here we have a couple of anxiety disorders, so social phobia and more generalized anxiety disorder. We also have major depressive disorder and PTSD, and some of you might be quite familiar with these terms as well. Now, they're what we call internalizing disorders because the symptoms are very much experienced within the individual. So feeling sad, feeling nervous, feeling worried. We also have 2 externalizing disorders. So ADHD that I mentioned before, as well as conduct disorder. Now, these symptoms, I guess for lack of a better explanation, are expressed outwardly. So the inability to sit still or being violent or being aggressive. So these are all of these on this slide are mental disorders. I just wanted to show you sort of the different broad types that we do see in adolescence. So I'm just going to touch on very briefly the definition of each of these, noting that each of these disorders, again, have very set criteria required for diagnosis. But social phobia is exactly what it sounds like. It's phobia of social situations. And the definition is there, so I'll let you read that. But essentially, you can imagine for a young person, so an adolescent, where they're now transitioning to have more impact on their lives by their peers and by social situations, how debilitating a disorder like social phobia can be. Related to social phobia is generalized anxiety disorder, or GAD, which is also an anxiety disorder, but is, I guess, more generalized, so more broad. So it's characterized by an excessive anxiety or worry about a number of events or activities. And importantly, that worry is out of proportion to the actual likelihood or impact of the event. Because it's quite normal to have some amount of worry about some things, but this is going to be quite excessive and it really disables the young person. We also have major depressive disorder. So most of you would be familiar with the concept of depression in some way, shape, or form. And depression is what we call an episodic disorder. So you can have ongoing episodes. It's characterized by a period of at least 2 weeks where there is a depressed mood or loss of interest or pleasure in nearly all activities. And there's other symptoms that need to be present as well. Post-traumatic stress disorder, again, relatively self-explanatory. It's development of symptoms after experiencing or witnessing an extremely traumatic event. And those symptoms, there's a range. They include depressive symptoms. They can also relate to experiencing flashbacks and those types of sort of hallucinatory symptoms, as well as avoidance of anything that may trigger that sort of memory. Moving on then to the actual externalizing disorders. So ADHD is this persistent pattern of inattention and or hyperactivity and impulsiveness. And again, it's important to note that with these disorders, these symptoms are more frequent and severe than in other children of the same age. Because if anyone has spent any time around a young child, particularly a 3 or a 4-year-old, we would say that all of them have hyperactivity because they're always very, very active, have difficulty paying attention, and that's normal for a 3-year-old or a 4-year-old. What we're talking about with ADHD is where there's a level of these symptoms that you would not expect of someone of a particular age. Likewise, with conduct disorder, it's a repetitive and persistent pattern of behaviour that violates the basic rights of others or major societal rules or norms. So thinking about aggressive behaviour, rule-breaking behaviour, and so on. And again, remembering what I said about adolescence earlier, we know that there is going to be some, as a natural part of adolescence, breaking of rules as adolescents push and find boundaries. However, what's important about this definition is that it is a repetitive and persistent pattern that specifically violates basic rights of others or social norms. So that is a very brief overview of some of the disorders that are common in adolescence. And the question then is, well, how do we measure these in the population? And there's basically two ways, if we're talking about public health or population measures, that we can actually measure these disorders. So the first is clinical assessment, and that's essentially clinical assessment by a psychiatrist or a psychologist. And that's often considered the gold standard because psychiatrists and psychologists are trained individuals and they can deep dive or really get into the individual factors around an individual. However, remember that we're talking about how best to measure mental disorders in the population as a whole. So if we were to try and do this on a large scale, so send out a whole army of psychiatrists to interview, thousands of adolescents, it would take a very long time and it would also be very expensive. And it would also be very difficult given there are obviously limited psychiatrists and psychologists and trained mental health professionals in all countries. So it's rarely feasible to do on a large scale. So in response to that, the other approach is to look at standardized tools. And really what I mean by that is structured questionnaires that match to the DSM-5 criteria. So they ask the correct questions to determine if someone is meeting the symptoms or the duration or the frequency required for a specific mental disorder by DSM-5. So the big advantage of these types of questionnaires is that they can be administered by a layperson. So I mean someone with no formal clinical training. They can be administered at the population level, so they are feasible for a survey or some kind of population measure. But it is worth noting that obviously these are very, very structured. So an interviewer or a participant will answer a question and there's no sort of further follow-up based on that particular answer. So often things can be missed or things can be overestimated, based on not being able to investigate those nuances like a psychiatrist would be. Also, most of the tools that are available that have been widely used have been developed with Western cultures in mind and then later adapted. So there is a big question around, are these suitable for use beyond the West? So touching on those different methods of measurement of mental disorders at the population, what do we actually know about the prevalence of mental disorders in Indonesian adolescents? So part of my background is work on the Global Burden of Disease study, which some of you may be familiar with. It's funded by the Bill and Melinda Gates Foundation and is run by the Institute of Health Metrics and Evaluation at the University of Washington. But essentially what GBD does is it uses all the available global epidemiological data, so prevalence, incidence, deaths, remission, and so on, to estimate the prevalence and the disease burden for different conditions, mental disorders included, across country, age, sex, and across time as well. Based on the GBD results, the prevalence of mental disorders in Indonesia in 2019 was around 10.7% for 10 to 14-year-olds and slightly higher for 15 to 19-year-olds at 11.4%. Also, GBD found that mental disorders were the leading cause of disability in both younger and older adolescents. Now, I'm going to take a risk here and try to show you some of the GBD visualizations, and I hope that that has come up on my screen. Excellent. So what we're looking at here is one of the, I guess, flagship GBD visualizations. So this is a tree map. Essentially, a tree map is just a square pie chart. So the size of the square equates to the amount or the proportion of disease burden or disability associated with a different condition. This is basically just a very visual way of showing you that mental disorders are the leading cause of disability in Indonesian adolescents. So at the moment, we're on 15 to 19 years. And you can see mental disorders here has the largest box. So mental disorders in 15 to 19 years are responsible for almost 21% of years lived with disability in Indonesia in 15 to 19-year-olds. Likewise, flicking to a different graph now, and I do apologize. What I should mention for anybody who's wondering about the different colors, blue is non-communicable diseases, red is infectious or communicable diseases, and green is injury. So you'll see obviously mental disorders are there in the non-communicable. So what this graph shows then is of all the years lived with disability, the proportion accounted for at each age. So basically this is just the tree map put into a bar for each age. So we can see how those proportions change across the lifetime. So we've got age down here, and then we've got proportion of total YLDs up here. So what I will do is just point out that, so the red is infectious diseases. As you'd expect, we see a lot of that in our infant ages, so our under ones. The blue and the purple in this instance are non-communicable diseases, and then we have our injuries down here. And what I'd just like you to note from this graph is that this dark blue section here is mental disorders. So you can see that mental disorders really start to contribute quite significantly to disability in the adolescent years, and then that continues throughout. And thinking back to what I mentioned about the golden generation and being responsible or seen as vital to Indonesia's economic progress into the future, the ages where mental disorders have most of their impact are the ages where you are expected to be most productive. So your key working years, and that starts in adolescence as well. So I guess just to note again that the impact of mental disorders in adolescence is important both now for the individual as well as for the future and also for the country more broadly as well. Finally, I just wanted to show you this, what we call an arrow diagram. And this shows the change in ranks between 1990 and 2019. And mental disorders have consistently remained the leading cause of disability in both our older, which I'm showing here, and younger adolescents. So again, I think it's just important to note from a public health perspective, really what a significant contributor mental disorders are to poor health in adolescents. So I will just flick back to my slide and then touch on challenges. So as we mentioned before, the definition of mental disorders, unfortunately, isn't as simple as taking a blood test. We are reliant on, these disorder classifications that have been created and that have evolved over time. Now, we don't have a special DSM-5 for adolescents. We don't have a special DSM-5 for children. It is one DSM for all ages and all countries. And I guess it's just to note that what DSM-5, can only do to an extent is recognize how different disorders look different in adolescents compared to adults. Similarly, we have this Western versus non-Western bias as well, and actually almost a very strong US versus non-US bias. And you even see that in some of the language in DSM as well. So one of these symptoms in ADHD acts as if, and in inverted commas, driven by a motor. Now, I think, what that's trying to get at is that the child is very energetic and never really sort of stops moving because they've got so much energy. But that idiom often doesn't translate particularly well, beyond the US, beyond Western context as well. So that can be a challenge in and of itself. As I mentioned as well, DSM has changed over time. So when we're comparing old data, so data from 20 or 30 years ago, compared to new data, often we're not comparing like with like because the disorder classification has changed. And there is also this question of the relevance of scoring algorithms across cultures. So DSM is obviously very focused on the actual cognitive symptoms, but we know in some cultures it tends to be the physical symptoms of a mental disorder that will be the primary manifestation of that disorder. So what I mean by that is one person may say, I feel stressed, I feel anxious, I feel nervous. Whereas another person who is experiencing the same thing may discuss racing heart or sweaty palms or muscle tension. So I guess it's just to keep in mind that the definition of mental disorders at its core also has some challenges, which then leads into challenges with measurement as well. So I mentioned translation. Amira, I'm sure, will touch on this on her presentation, but as part of our project, we had to do a significant amount of work on translation because the instrument we were using was not just very westernized, but was very US, I guess, developed as well. So there was a lot of language that even myself as an Australian, I wasn't familiar with in that instrument. So there's that happens as well. And also in one language, it's one word. In another language, there may be 20 different ways of describing a particular thing and vice versa as well. So I've mentioned the culture and the language. There's also this question about standardized tools and their appropriateness for different cultures with how they're delivered. And I'll use the example of a colleague of mine who is conducting a survey of mental disorders in Indigenous Australians. And these structured tools and the way of asking the questions are not really how those questions would normally be asked in these populations. And they can sometimes come across as quite rude because that's not how conversations are had. So I guess just to note that there are these challenges with definition and measurement. It's not that they can't be overcome or that they can't be addressed as much as possible, but I think it's just important to be aware of these extra difficulties we have when we look at mental health in the public health arena, as opposed to some of the more physical disorders. So the next, I guess, limitation is around, well, the existing data that we do have for mental disorders. And these issues relate to Indonesia, but they also relate to basically every country as well. So what data do we have on mental disorders in Indonesia? Well, we have data that reports mental health problems, but not mental disorders. So they'll often use short symptom measures, not those comprehensive diagnostic tools that I spoke about before. And that means we don't know much about mental disorders specifically, and most importantly, what services or supports may be required. Of studies that do use the standardized tools, often they're quite small because these studies are not particularly easy or cheap to do. So they'll have small samples that may be restricted to certain cities or certain populations or even certain points in time. So, for example, an Indonesian study investigating the prevalence of mental disorders in children and adolescents found almost 9% met the criteria for any mental disorder, but that sample was only included young people exposed to the tsunami disaster in 2004. And obviously, this is a really important study, but we can't use that to generalize more broadly about mental disorders in the Indonesian population. Finally, the question I get asked a lot is, well, what about the data from hospitals and the data from clinics? And that data is very valuable because it shows us who is accessing services. The downside is that it only shows us who is accessing services or who has been able to access services. And considering we know that most young people with mental disorders either don't seek or don't receive help, that data doesn't give us the full picture. So a 2016 study then analysed, well, the mental disorder data that does use those diagnostic measures on less restricted samples. So it looked at the data that's included in the Global Burden of Disease study. So the data that sits behind those visualizations I showed you before. And what that study wanted to do was to work out, okay, of the data that we have for children and adolescents, what proportion of the global population of young people does that data actually represent? So how many people in our population do we actually have data for, or what proportion do we have data for? And globally, it's only 5.7% of the population is represented by the data that we do have for mental disorders in children and adolescents. And that proportion changes when we look by country, as you'd imagine. And for Indonesia, at least by the time that study was published, it was less than 0.1%. So then the question is, well, why does this matter? You know, is there any real impact of not having this kind of data at a global level? So just very quickly, I'll show you this graph. This is the prevalence of mental disorders for 10 to 14-year-olds over time. So 1990 through to 2019. And this is prevalent cases per 100,000 in Indonesia. Now, as you'll see, these are our estimates, our dots here, but they are surrounded by very large uncertainty intervals. And that's because of the model is based on very little data. And the problem with that is that we can't see, has there really been a change across time? Has there been an increase, a decrease, or have things actually truly stayed the same? And if we don't know if things have changed across time, then we can't see, well, is what we're doing now working? Do we need interventions? There's a lot of questions that we actually can't answer. And without good data, we can't make good decisions. And that's why having data, at the country level is so important. I think, spoiled the surprise with this. But this graph is basically the same again. It's just showing a few different countries, across time from 1990 to 2019. And Indonesia, as you see, was that dark green line there. So staying relatively flat across time. Now, country comparison can be quite useful because we want to see, well, what are different countries doing? What interventions are they using? What policies do they have? So that we can learn lessons and learn, what might work in our population, or also what might not work or what hasn't been working. But again, we need accurate data and accurate models in order to do that, and models that shrink those uncertainty intervals. Because if we actually put uncertainty onto this graph, you'll see that virtually every country overlaps. So we can't really tease out any real differences. And again, without good data, it's really difficult to make good decisions. And that applies from policymakers through to clinicians. So normally I don't finish off on sort of a down note, but I know Amira is going to be presenting on some really exciting work that's being done. So I will finish by saying currently there is no nationally representative study reporting the prevalence of adolescent mental disorders in Indonesia until now. And on that note, I will leave you with Dr. Amira Wadi. Thank you so much for the opportunity to present, and I look forward to the discussion at the end.
Yeah. Thank you very much, Dr. Eskin. It's very interesting talk. We know the type, various type. We learned various type of mental disorder in adolescent that can be classified based on a set of symptoms as well as certain durations. And also we learn about the current challenge, especially to estimate the true burdens of mental disorder in adolescent, that it still remain challenging at the moment. I believe that the audience have many burning questions, but apologize that we need to hold the questions until the question and answer session, and I hope you don't mind to wait until we finish Dr. Amira Wadi presentations. Thank you. Bapak Ibu sekalian, saya ingin memperkenalkan dulu untuk pembicara kedua, Dr. Amira. Saya rasa ini pasti Bapak Ibu sudah banyak yang kenal karena Dr. Amira sangat populer ya. Jadi Dr. Amira Wadi, untuk saat ini beliau adalah salah satu dosen di Department of Biostatistics, Epidemiology and Population Health, Fakultas Kedokteran, Kesehatan Masyarakat dan Keperawatan Gadjah Mada. Beliau juga researcher di Center for Reproductive Health, University Gadjah Mada, sekaligus juga merupakan National Consultant untuk UNFPA Indonesia dan juga Kementerian Kesehatan Republik Indonesia. Beliau menyelesaikan gelar dokter pada tahun 2013 dari FKK MK UGM dan kemudian menyelesaikan gelar Master of Science in Public Health Program Department Populations, Family and Reproductive Health Johns Hopkins Bloomberg School of Public Health di Amerika. Dan beliau banyak sekali terlibat dalam penelitian-penelitian khususnya terkait dengan kesehatan remaja. Dan saya tidak akan menunda lagi, Dr. Amira, silakan untuk dapat mempresentasikan. Terima kasih.
Terima kasih, Dr. Tika. Okay. Thanks before for the segue, Holly. That would be lining up nicely with my presentation. So, just to summarize what we've heard before from Holly, why focus on adolescents? Why do we need to talk about mental health in Indonesia? And what will research on this issue will bring or contribute? And then we will focus on our discussion on how is the current state of mental health research in Indonesia, particularly for adolescent health. So, just to recap a little bit, we know that this is an important phase in life. This is an important part in our life cycle, being an adolescent. And I believe that some of you are much younger than me, and you can remember it better, how confused we were during our adolescence. And sometimes when things already, like not supported well during this critical period, because sometimes we just like forget about the fact that adolescence is the second critical period in our life. So yes, we developed, we grow and change our childhood, but after that, adolescence is the second most important cycle in our life. So because of that, we really need to invest on adolescent health, and the fact that being healthy is not just absence of disease, but also the state of our mental well-being. This is the reason why we need to pay attention on adolescents' mental health. So, like Holly already stated before, the fact is we don't have a national representative data on the state of adolescent mental health in Indonesia. We do have what we call Riskesdas. I believe almost, like we are familiar with this research. So basic health research, the latest data was released in 2018. And this survey has almost every cycle. It asks questions about mental health, because the awareness the awareness about mental health started only like maybe in the last 1 or 2 decades, and along with this awareness, the Ministry of Health tries to, to show their commitment in collecting the data on mental health in Indonesia. So they put some questions regarding mental health in Riskesdas to get a sense of the state of mental health situation in Indonesia. But this research, Riskesdas data, is what we call symptom-based research. So instead of diagnose people whether they have mental health or not, they just ask whether they feel or they experience some symptoms that will line up with mental health, mental disorders symptoms. And there is a problem with this, not a problem, but there is a limitation, I think. There are some limitations on this. First, because of the lack of awareness on mental health, even when you feel that symptoms, you will not recognize it as a symptom. So again, I'm reflecting, and this might be a bias from me, but before I also didn't really pay attention on my own mental health. But since I started working on this project, I realized that, yeah, I've been dealing with quite a lot actually, but because I didn't have awareness that what I experienced before were symptoms, I didn't realize, I didn't do anything. And I'm still struggling with it. So because of that, the number that we get will always be just, the tip of the iceberg. And even after that limitation, the questions that Riskesdas ask limited on psychosis, limited to psychosis and depression. So because the concept, or maybe the way we look at mental health, we look at mental health as we only look for the most severe type of mental disorder, so schizophrenia, for example, or other type of psychosis, which is a valid health problem, but compared to other type of mental health, mental disorders, this is only also the type of the iceberg. Depression as well, of course. Depression is more of, uh, it's nearer to what kind of mental disorders that we discuss here. But because of we are talking about symptom based, even people who like clinically depressed, if they don't realize, they don't know what depression is, it's hard to have a sense that yes, I do have a mental health condition that I should take care of or should get treatment for. So this is some limitation, and also but there is some some interesting and interesting part of risk assess that we should appreciate, that it asks about stigma. So we know we have a sense of, okay, this is the challenges that we have in the field. What kind of stigma around mental health that's we have in Indonesia, because risk assess is nationally representative survey, and it also assesses the barriers to care. So we know the distribution of mental the service provider for mental health, and where we should invest more on this topic or on this issue. And one other thing is risk assess is also limited to age range 15 years old and above, so 15 years old and older, which like for not bad for a national representative data, but when we, of course, we then cannot really rely on this survey if we want to talk from adolescents health perspective, because based on WHO, when we talk about adolescent, it means that we're talking about children, so to speak, or young people between 10 to 19 years old. And this is important because most of mental disorders that happened around young people occur early in the life cycle. So it might be late childhood, early adolescence, preteen, so to speak, and young or early adolescence itself, and basically younger than 15 or around 15. So it's really important to get that to include that age group in our research. And we also need to acknowledge many institutions, NGOs that work on adolescent health, child health, family well-being, and of course mental health, that they also contribute in conducting smaller research, but still important for us to get a full full understanding about what's going on, especially if we want to focus on limited or smaller scope, but smaller but specific scope, like children with HIV, for example, or children who live, like in institutionalized institutions. So in orphanage, for example. So this is still important. And then we move forward to Indonesian National Adolescent Mental Health Survey. So this is a project that I've been working on since 2018. And I don't know if Holly knows this, but I just returned from United States, and I don't know about you guys, but if you already worked for a while and then you took a year or two off to continue your education, it could get it could be hard when you return because, like you've been off for a while and your office will, like go on without you. So, but at that time, I didn't have anything to do basically. So I've been going to the office every day, just, having chat with my colleagues and bothering my boss. Because no specific job for me. And then Prof. Siswanto that you already met, weekly for Biostat, said to me that, hey, we will have an upcoming research collaboration with UQ and Bob. So I never worked with University of Queensland before. I never worked with any colleagues from Australia before, but I knew what, like Bob, when Professor Swanto called Bob, he referred to my professor at Johns Hopkins, Professor Bob Blum. So, and I said, okay, so this would be my project. And and then he told me that it's about mental health. And I was like, I didn't know anything about mental health. Like I literally don't know anything about mental health. But because at that time it was my only option, and everybody else already had something to do, and obviously I couldn't just like ask somebody else to take double burden for this. So, and I said, okay, so I should learn about mental health, and that would be the best serendipity occasion, incident, or situation in my life, because not just I learn a lot, not just I'm doing something that hopefully will contribute to the state of mental health in this country, but it's also me helping myself so I can have a better mental health, I guess. So it was October 2018. We met together. So the umbrella name of this project is NAMS, National Adolescent Mental Health Survey. And there are 3 countries involved in this project. Involved here means that where the survey takes place. So we have Indonesia, of course. We also have our colleagues in African Population and Health Research Center in Kenya. So we have another research, the similar research done simultaneously, not necessarily simultaneously, but in the same manner, with the same standard in Kenya. And we also have colleagues from Vietnam Institute of Sociology. So this survey also was conducted with similar manner in Vietnam. And other than us 3, of course, there is the University of Queensland in Australia, particularly the Queensland Center for Mental Health Research. And of course, there is Johns Hopkins University in Baltimore, United States. So we met together, and then we start, working on the preparation. So just to mention it briefly, actually, there are 3 arms of this research. So first, we have what we call pilot study. So of course, before we go to conducting a national survey, we have what we call pilot study. Test the instrument, which I will mention again later on, and we have what we call clinical calibration. So, but for this clinical calibration, I will not explain it much because it's literally like we can have a separate session for this, but we do have what we call clinical calibration and national survey. And for this, the last, the rest of the time, I will talk, when I talk about INAMS, I will refer to the national survey. So Indonesia is a big country, right? Even we here in Center for Reproductive Health, we've been, we've been working with so many national representative studies, but we never do it alone because it just like, yeah, we don't like to torture ourselves. So we called our partners, and we've been working with Universitas Sumatera Utara, with USU, for since I don't know, maybe 2015, if I'm not mistaken, and also Universitas Hasanuddin, Unhas in Makassar. So in total, we have 188 enumeration areas across Indonesia, all 34 provinces. And just for the sake of, better management, monitoring, and evaluation, 23 of these EAs were managed by USU in Medan. So basically, they own all Sumatra Island, and 50 EAs belong to Unhas. So they manage Sulawesi Island and the eastern part of Indonesia. And the rest, the biggest chunk of the enumeration areas, with 115 enumeration areas, were managed by UGM. And we also have two oversampled district, kabupaten and kota, because with this survey we will have what we call national representative data, but we also would like to have what we call district level representative data. So we would also want to have estimates in district at district level. So we choose Purworejo, just 2 hours from Yogyakarta, because we've been doing what we call demographic health research there for even when, it started when I was a kid. So early in 90s, they already started this research there. And we also have one other oversample region district in Palu, because we would like to know the state of mental health there among adolescents after the tsunami. If you remember, that happened like maybe 3 years ago, if I'm not mistaken. So we in doing all of this, we were supported by more than 200 field staff. So it's a big team. And of course, because the idea to do this research is to provide Indonesia with a better data, just like what Dr. Erskine already explained before. We don't just do this for fun. Of course, it's fun doing this work, but it's not our end game here. We would like to provide the country with a better data. So eventually, we will able to create better policy. So we will improve the state of adolescent mental health in the country. So because of that, we engage the Ministry of Health right from the start. So in the meeting that we have in 2018, one representative from Ministry of Health joined us just to, give their perspective on what kind of data that they would need, and what is the challenges that they have so far, so we can design our survey around that. And also, because this is the national representative data, we need the data about the population in Indonesia. And because of that, we also work together with Statistics Indonesia. This is the fancy name this is the westernized name of BPS, Badan Pusat Statistik. And one strength of from these surveys, this is a diagnostic. This is based on diagnostic, not symptomatic. So we do ask about their symptom, but because of the instrument that we use, we will then able to diagnose whether this person have the disorders that we are looking for or not. And not only that we assess their mental health diagnosis, mental disorders diagnosis, we also look for or collect data on protective and risk factors. So, the variables surrounding that state of mental health, and also the service utilization. So whether they access health service, what is the factors that will influence them to access that. We have that in this survey. And this is also, like Holly already mentioned, we try to be culturally sensitive, as culturally sensitive as possible. So because of the instruments in we developed, so some of the instruments are already there before the survey, so ready to use, but some of the instruments we developed together among all countries involved. So of course, the original, the language that we use is English, but then we translated into Bahasa Indonesia, and then back translated into English. We compare them together, and because we are not just talking about Java Island here, and we send all questionnaires to our colleagues in USU and UNHAS. We also send the instrument to our colleagues in Faculty of Psychology, and we then receive all the input. Like our colleagues from USU and UNHAS had so many lists that, hey, this kind of question will not work in our neighborhood or our culture, our language, things like that. So we try to be accommodated on that. Of course, we cannot solve all problems or all discrepancy, but we tried our best. And because we
have 2 minutes left. Sorry.
Yes. Yeah. Because we also have pilot testing. We test that, and we did the test on early, just before the pandemic in 2020. So this is the diseases, the disorders that Holly already mentioned, and this is the instruments that we use. So we have what we call DIS-5, and this is what we coded by blue, and then we have what we the instruments that we developed by ourselves. This is what we coded by green, and there are also two instruments that specific for INAMs. It means that developed specifically for INAMs and will not be found in Kenya and Vietnam. So again, like Holly already mentioned, the problem with DIS-5 is because it's too United States, so to speak, and there are and this version, version 5, has never been tested before or used before outside United States of America context. So Holly, if you know that if there is any development on this particular issue, if it's been tested or used outside United States, let us know. And of course, there is also some challenge in like the not specific challenge in working with adolescent mental health surveys. First, we need informed consent, not only informed consent, but informed assent, because we need to ask the adolescent also whether they want to participate in our research or not. And then we need child protection protocol, because sometimes you will discover that, I've been trying to do, I've been trying to kill myself for 3 times now. What should you do then? So we need a protocol for child protection. And then, of course, because it's in the middle of pandemic, when we do this, we do the data collection starting March this year up until December 15. So we have what we call COVID-19 prevention and management protocol. And also, again, because we talk about something that could be triggering, like in one question, I remember there is a question about, have you been, so yeah, this is me just, like what I remember out of my head. Do you have you been sexually assaulted? So, and it could be triggering, and you could have a distress out of this question. So we need to have a specific system to deal with this issue. And of course, because for this survey, we collect the data using smartphones. So all questions are programmed in smartphone. So we need to abide based on, like to the law, the data protection law that we have in Indonesia. So now we already finished the data collection. Of course, we still in the middle of data cleaning, not even the middle, we barely starting data cleaning and data preparation, and then eventually data analysis. But at least, so whatever it is that I'm saying now, it's not the end conclusion, but we can see, we can sense, from our experience this year, we can see that the prevalence of mental disorders are within expected numbers. So we know that this specific disease will have a higher prevalence compared to other. And we can see an indication that some questions might not perform well. So they don't collect the information as we expected them to be. And that some questions might be hard to be accepted in specific culture. So this is not a surprise, but yeah, we see, we kind of tried, right now we kind of try to identify this question. So what do we learn? So I guess I'm just asking for a couple of minutes time. So we obviously need to continuously adapt the instrument. So revise the questions maybe, or maybe try to find more specific or more culturally appropriate examples that we use in the question. And because this is important, because the idea is if this 5 performs well, we might be able to use this on in a bigger scale. So let's say that this 5 is available in all puskesmas in Indonesia. So if there are people or adolescents who would like to, to consult the health providers regarding their mental health, and this puskesmas doesn't have clinical psychologists or psychiatrists, a nurse, a trained nurse or a midwife can just use this 5 to screen or to diagnose the adolescent, and then refer the adolescents to the higher level of care. And it's because we still, like from the experience, from our enumerators' experience, we know that we still need to work on advocacy and generate needs and eventually help-seeking behavior. We see that people are still some, kind of just care about this issue. And of course, stigma is still a problem because we face some rejection as well, just because of stigma about mental health. And the fact that training is the most important part of conducting, for conducting survey like this. Training is the most important part other than preparation. And we developing and conducting training during the normal time is already challenging enough. But now we did that during pandemic. So I'm really grateful and proud of our team that try to deliver the best training possible, albeit, like we're in the middle of pandemic and we need to cut short the training. And we are lucky with our that we have a good partnership and we have a good stakeholders engagement. So we have an optimism that this could be a start of something good. So, and this is just the beginning. We just conclude the national survey. We will know more next year once we finish data analysis, and I believe that there will be a stream of publication regarding this issue. And it's also an open invitation for everybody who see that this is something important for them, that this is something that they can see themselves work on. We will need your help in, just managing the data, analyze the data further, and work on advocacy based on this data. Because, we only, have less than 10 people here. It's impossible to do them all. So I guess that would be all. Yeah, this is the next step, of course. And yeah, this is all from me. Thank you so much. And I can't wait to see, to discuss it further. Thank you.
Thank you very much, Dr. Amira. It is very exciting to know how the result, and please share with us when the result is available. And also, many questions in the chat box. I'll start with the first questions from Bapak Ahir Fahrudin. He was asking about what could school and adolescent do to promote mental health, especially during this pandemic times. I guess maybe Dr. Eskin or Dr. Amira, do you want to address the questions first?
Yeah, look, absolutely. And I will just note that, obviously I'm not a clinician. I'm more sort of public health focused. But it's an excellent question, and also I think particularly important. And I guess it's just about having the conversation, at the very least, having the conversation with adolescents that, mental health and impact on their mental health, this is something that they may be experiencing, and, just giving them a place, a safe place to talk about it. And it doesn't need to be very clinical. It doesn't need to be very detailed. But if they can just have a safe place to talk about how they're feeling, that's really, it's a simple step, but it's one of the most effective first steps, at least in my opinion. Obviously, Amira, you may have a better sense of this than I do.
Holly, this, it's totally, you emphasized a great point there. And I guess specific for Indonesia context is what we can do in our schools is try to educate the teachers, I guess. So we start from the teachers, because right now, just one example, when there is a bullying, I believe that it was on paper, maybe early this year, when there was a serious bullying, like somebody literally beat up, like a student literally beat up another student. And then at the conclusion, at the end of the news, you can see that, you can read that the school offered both parents to just, trying to make peace to each other. So so they basically just to ask both students to make peace to each other and be friends again, instead of, discussing or really delve into what is the cause of this behavior, what's wrong actually. And this is important, because if the teachers or the stakeholders in this sector don't even acknowledge that there is a mental health needs in this issue, we will never move forward. into a better situation. So at first, I guess we need to start the awareness from the teachers. Like, I guess that would be the first step. So yeah.
Thank you. And for the next question, I think it's very in line with the previous questions from Pak Yusuf. He was asking about that bullying during adolescence is sometimes considered as a normal things occur during adolescence throughout their adolescence, and how it may have the long-term impact to the mental well-being of the adolescents, and then and how to create a sort of like a bullying-free environment, and whether I know this is long questions, and whether what does that mean that those who are doing the bullying they also have a mental problem. So it's not only focused on those who are like the victim of the bullying, but also the one who practiced bullying. Yeah, thank you.
Thanks. Again, that's a great question. And so part of my work actually has been to have bullying included in GBD as a risk factor. So as smoking is considered a risk factor for lung cancer in GBD, bullying has met that threshold, or being a victim of bullying has met that threshold for anxiety and depression. So now we actually can quantify the disease burden in depression and anxiety that is due to being bullied during childhood. So bullying is, I guess it is, even in Australia, considered a standard adolescent experience. Most of us have gone through it. But that doesn't mean that it should be, or that it has to stay that way. Bullying isn't something that has to happen. It's just something that has become accepted. And because we know that bullying can lead to mental disorders during adolescence and can have long-term impacts, trying to intervene in bullying is really crucial, and it's a recognized, as I said, risk factor. I'll just jump to your third question around what we call the perpetrators of bullying. So I guess, we wouldn't say that someone is a bully because they have a mental disorder. That's not, how we look at it. Often people who become bullies maybe have some other risk factors going on. So great difficulties at home, potentially some other issues going on, and it's coming out and being expressed as being a bully. What I will say is that we do see that both being a victim of bullying and also being a bully can lead to developing mental disorders. We find that there are individuals who are both victims and perpetrators of bullying. So there's actually 3 groups as well. And each of them has a more unique pathway and a unique relationship with different mental disorders as well. So intervening on bullying should most definitely not just be focused on the victim, but also the perpetrator, because it will improve the lives of both of them. Now, that being said, I think trying to create a bullying-free environment is really challenging, particularly now with social media. Bullying at school is now going beyond school. And there's, at least in Australia, a lot of discussions around, where does the school's responsibility end? Where does the family's responsibility begins? If you're being bullied online, but you're physically at school at the time, is that the school? Is that the family? So I think there's no simple answer to that question at the moment. Certainly in Australia, we haven't found it yet, but I think it is recognizing that this is a really important issue, and it's a risk factor that we can address somehow as well. Sorry, Amira?
Yeah, I agree. I don't think I have much to add, but it's at this point because the question asks how we can create an environment that free of bullying. This is a reminder for me, at least, that to make sure that I walk the talk. So you can start from home, from your office, and once I see it, once we have a healthy environment in our office, for example, when a person move to another office and see that, hi, this is not really healthy, he or she will start speak about this issue, and at least try to spread the 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 idea that we should have it. And when we teach our kid about this, our children about this, that like how to respect others and how to manage their emotion, I guess one of the reason why this is so prevalent among adolescents, because they're still trying to manage their emotions. So instead, because they see bullying, being a perpetrators, for example, is a way to express their emotion. And because now it seems like just accepted, it's never okay, but it seems like accepted. They try to, like it's built in their mind that, okay, this is a way to go, and that's wrong. So again, this is a big work. And but rest assured that the government is starting to work towards this, to make the condition better. Starting next year, there will be a series of massive training for teachers in tackling for delivering comprehensive sexuality education. And mental health is attached to that, because being adolescents, you cannot separate reproductive health, sexuality, and mental health. So I hope we will see the impact from this program.
Thank you very much. It's there is no, like, we need to balance between family role and school roles in terms of preventing bullying. And sometimes it's hard when the parents or the family, when the kids arise, they're very abusive, although it's like a verbally abusive or physically abusive. It sometimes happens for a certain family. And how do you manage that, Holly, in Australia, when for a family or those who become a bullier, and for those who have problems with their family, they don't have support, they have it's like violence within the family group. It's something that usual. So what do you do for that? What do you do in Australia for that?
Look, again, a really good question, and I think it's a difficult answer. I don't think we answer it particularly well, and it depends on the individual situations as well, what services they have access to, the extent of the bullying, what's been involved. It's a question probably I wouldn't feel comfortable answering, at least from my background, but it's definitely one that I'm happy to take to our child and adolescent psychiatrist, James Scott, who's working on the project. So any questions that I'm unable to answer here at the moment, I'm very happy to take away. So Vicar, if you wouldn't mind emailing me any outstanding questions after, I can definitely follow up. But I think, at least from my experience, it's not an easy answer.
Yes, thank you. So we'll go to the next questions from Sylvia here. She was asking that the Ministry of Health actually have the mental health screening for adolescent annually, and it is being held in school. But during the pandemic, there might be some disruptions with those strategy. And then, would you suggest any monitoring teenager, especially for the mental health tool, or other methods, especially during pandemic, and to be set in the developing country?
Yeah, I think, again, it kind of comes back to Amira's point around the suitability of the instruments as well. So at least from instruments that I am confident have been adapted to the Indonesian context, because Amira and her team are the ones who've adapted them. There are short ones like the Patient Health Questionnaire 9, which is a measure of depression. There's also the GAD-7. Again, that's a symptom measure of anxiety. There is also one that we are using in NAMS across the board called the PSC-17 that was actually built for clinicians and covers both internalizing and externalizing. So there are some shorter, freely available, symptom screeners out there as well. But I guess I would view those as just the first step in, determining whether an adolescent, may or may not need some help. Amira, that's just my thoughts on that side.
Yeah, and Holly, if you remember the screening test that we talk about during our clinical calibration, this is the program that we talk about. So, and like this is not isolated to mental health. Almost all routine screening in Indonesia experience disruption because of COVID-19. So this is just something that we need to deal with. And you highlight a good point that we are struggling to keep the program alive during the pandemic, but at some point there are also some puskesmas, for example, that could find a way to adapt during the pandemic using the local community. And I learned from some of you, I guess, that because puskesmas during normal time we'll need to send or give the adolescents iron tablets, for example, for female adolescents, and because they cannot go to puskesmas, so they work together with schools. So puskesmas will go to schools, left the package along with the assignments package, the school package from the government, from the local education office. Then the students or their parents can just make an appointment to take that package together, like at once. And the instruction and the monitoring and evaluation will be conducted via WhatsApp. So when we talk about this, it's not just for the iron tablet, but also for the screening questionnaire. So when you realize that your neighborhood is not good with smartphone, when smartphone is not widely available, then paper-based questionnaire can be an option. So it's really about knowing your neighborhood, have a good communication with them, and decide together what should we do about it. It cannot just be one-sided. So it's hard, I know, and this is not just for mental health, but we also see that some people perform really well, and we can learn from them.
Thank you, Dr. Amira. The next questions, it's saying that speaking about mental health, sometimes it's taboo in our cultures, and then how we may increase the awareness about the mental health in the community without being worrying about stigmatize the individual they are being diagnosed or found to be having mental health issues. Thank you.
I mean, I guess from my perspective, and this is from a very broad, obviously non-Indonesian specific perspective, increasing awareness actually does help reduce the stigma. So the fact that there are projects like INARMS that are happening where young people and their parents are being specifically asked to speak about mental health and the risk factors related to it is absolutely vital. And I think there are a lot of different ways to reach both adolescents and also their parents as well. And normalizing mental health just as like another health condition like physical health is really such the way forward. And it doesn't need to be very clinical language, social phobia and ADHD and conduct disorder. It just needs to be creating those safe spaces for discussion about how people are feeling. And then at the same time, having at the policy level and at the organization level, people leading by example. And I think speaking freely about mental health, as Amira did in her presentation, and also having health professionals feeling comfortable asking about mental health. Really, the key is to, I think, normalize it as much as possible, as has been done for other health conditions. And what we find with that is that there's a snowballing effect. Awareness increases, stigma decreases. It's a long road. We're still walking down that road in Australia, and the rest of the world is as well. But the first step is just awareness and leading by example and speaking freely.
Thank you, Dr. Amira. Do you want to add, or should we go to the next questions?
Well, I think from if we want to see it from Indonesia's perspective, we also need to engage more community gatekeeper, I guess. So awareness that comes from the community gatekeepers, I think that would be the best one of the best approach that we can do. Like we have like so many Indonesians engage with social media. So once the influencers talking about mental health, so people will pay attention. And if we want to reach the older generation, once the religious icon starts talking about mental health, then they will listen. So yeah, that would be more. We need more awareness from right people.
Yeah, I think that would be a very great strategy to engage with the influencers. And the next question, I think after we're raising awareness, the other problems is that we are currently lacking with people who can do consultations with regard to adolescent mental health. And then how do the Australian school manage to have staff to do that job? And maybe we can adapt with a certain strategy that you may want to share here.
Yeah, again, look, a really good question. I think in Australia, often the approach will differ by state because our health system is very state-based. But in general, schools will have some kind of school counsellor or mental health professional, or mental health nurse available. That does differ by public and private schools. It does also differ depending on if you're in a big city versus country as well. In Australia, we are also very fortunate that there's a certain level of mental health care that is included in our universal healthcare coverage. And that does cover, access to a psychiatrist as well. So actual specialist access for certain things too. So this, I guess, challenge and really initial question we had with doing NAMS, the NAMS project in any country was, what happens if we find a problem and we can't do anything about it because there are no services? And it is a question that we did really wrestle with. But I guess we're in a catch-22 situation because the services aren't going to come about until we can show that there is actually a problem in the community as well. And we found this when speaking to our colleagues from Kenya, because as Amira mentioned, as part of our survey, we do offer, every participant gets a list of mental health services that are available close by, regardless of what they've actually said on the survey. And, that in itself is quite a big piece of work. And our psychiatrist from Kenya said, well, we don't have any services, but we're only going to get services when the findings of this study come out. So, I think really what we need first and foremost is that data that I mentioned and that INAMS will give, so that we can advocate for these kinds of mental health services in schools as well, and also demonstrate the benefits of early intervention as well. So not just addressing mental disorder prevalence, but reducing mental disorder incidence as well. I think that's absolutely key. So the Australian model, you know, we do have that kind of a model of someone in schools and access through universal healthcare, but that has come about as a result of large-scale surveys similar to INAMS.
Thank you. It's very interesting to know that we need to understand the exact burden before we plan about what's the next step to overcome the burden, of course. And the next question, if I understand correctly, so how the field worker then use your research result to then bring the informations to the district level and then inform or increase awareness about the mental health. Is that a part of your plan as well? I think you still mute, Dr. Amira.
Okay, so this is important and this is a good question. When we talk about, again, because mental health is really interlinked with the cultures and the local context. So I guess the first step is to, at least if we, once we have the data, once we have the result, the information, if we can bring this result to the local stakeholders, so they can start looking at the burden itself. So this is the burden. If this is the Indonesia's, the country's burden, so they can imagine that the district's burden might not be really different from this, and they can look at the protective factors and risk factors, and then they can also reflect on the district's situation. If they see that, like for example, smoking is correlated with mental disorders, for example, and they can see that in just, like from daily social activities that most of young people smoke, they can start, okay, this could be a problem. Or if they see that, again, the local school don't have support to tackle mental health, they can invest in that. So I guess the starting point is just to bring the data to the, to the smallest administrative level possible. Because this is not just, top-bottom approach. We cannot do that. It will be impossible. So we also need engagement from the grassroots, from the community, from local village community to start speaking about mental health based on the data. So the goal from INAMS is, of course, we will have like research report, but we also will generate policy briefs so the stakeholders can use it. And we will, the idea right now is to develop kind of 2-pagers that just full with, visualization or take home points that easy to understand, eye-catching, so it will be easier to distribute. And even, we hope it will be easier to use. You don't need to have a master degree of PhD to understand about what we're talking about. So hopefully it will be more useful.
Do you have anything to add, Holly? Or
I think Amira's covered that one really well.
would you also address like different patterns, like sometimes the problems is different between, like province or district across Indonesia? Would also be highlighted in the result as well? Yeah, okay. The next question is, it's from Pak Bangun. So the adolescent mental health sometimes is not become a major concern in the society. Are there any study that comparing the differences of mental health before and after pandemic, and then that during the pandemic, they're more likely to stay at home and parents may not be aware with, mental health issues. So is there any way to help addressing this during these situations?
That is a brilliant question. And I know that there is actually some work currently being done by the Global Burden of Disease Study to try and compare the before and after impacts of COVID on mental disorders, as well as other, conditions as well. For anyone who's interested, my colleagues recently published a paper in The Lancet, I think, that looked at the impact of COVID on depression and anxiety. The challenge with trying to look at differences before and after, or before and during the pandemic, is we actually don't have that much data from before. So you remember from my presentation, there was actually a big lack of data. So trying to do comparisons, globally can be quite challenging. But that being said, at least in NAMS, for all of our NAMS countries, we are asking questions about COVID, and we are hoping to be able to basically group people based on their exposure to COVID. So, no exposure, their family wasn't impacted, their economic well-being wasn't impacted, and then have a more moderately impacted group and then a severely impacted group, and look to see if there are any differences in mental disorder prevalence, or at least the risk factors by those groups as well. So unfortunately, we're not in a position to do kind of longitudinal analysis, but we're hoping to be able to draw some conclusions from that data.
Thank you very much. The next question is asking for Dr. Amira. Is it possible to use the INAMS data for thesis and maybe publication for students?
Yeah, that's always the idea. But we will have the formal mechanism soon, I guess. So we're not in that phase yet because we are still doing data cleaning and everything. But yeah, I'm afraid that I'm afraid that it will not be available until mid next year. So that would be the best scenario possible, that it will be available. The data will be available for, wider use by 2022. But I guess this is something that we still need to be discussed internally, but rest assured that's always be the goal. So sooner or later, you will see an announcement that, hey, we're looking forward for graduate students interested in adolescents' mental health data. So yeah.
Thank you, Dr. Amira. So, the next question is from Bu Valentina. She's asking about what are the best, maybe the best or valid standardized instrument that can be used to screen mental health in adolescents. And because currently with the programs that is running, they're using different type of instruments, and whether those kind of instrument can be used online. And if it is can be used, then what are the challenges that can be faced?
So I think we sort of did touch on some of the, I guess, standardized, instruments. I think another outcome of INAMS in terms of screening tools will be some of the other instruments that we've included, like the PHQ-9, GAD-7, PSC-17. Screening is really valuable. It gives us a first step in working out what the prevalence actually is, and gives us sort of some initial data as well. Instruments like that have been used online as well. I guess there is always a question of both the data quality and also the sample that you're accessing as well. So obviously, if a study is done online, you're only potentially sampling the people who have access, to a computer or to the internet as well, which can bias age, it can bias, location and so on. But I think it's definitely a possibility. I think it just needs to be seen, I guess, as one part of sort of the whole research, enterprise and what's required. But I think that's just, from my perspective. Amira, I'm sure you've got some thoughts on that.
I guess this is a little bit complicated because, just from the administrative point of view, when we talk about Puskesmas, for example, or any other programmatic screening in Puskesmas, the Ministry of Health doesn't have full authority anymore. They can give the Puskesmas resources, they can give Puskesmas support, but at the end of the time, that would be the province's authority to shape the health program in their region. So when we talk about standardized instruments, for example, it will be really based on the region. But what the idea right now is to find the best and the best instrument based on the region's need. So, for example, if you live in and again, when we talk about screening, it's not just to screen somebody or eventually diagnose somebody, but what kind of support, what kind of healthcare that then we can provide for them. So it's easy for us to talk about a screening program in Java, for example, because it's definitely easier for us to access mental health care in Java. But when we talk about this in Kalimantan or Sulawesi, then the government there will think twice. First, do they even have, resources to do this? When we talk about these 5, for example, in a scenario when we can adopt this beautifully and ready to use in Puskesmas, for example, we still need to train the nurses, the midwives, and whether they be ready for it, whether we have resources to train them, whether after receiving diagnosis or the screening result, we can refer them to the higher level of care. So this is not impossible, but definitely we need to see this in not just in mental health context, but in the broader context, in the health service context. So we can talk about the needs of the population. If obviously here we have 6 mental disorders, but some regions might be we only worry about depression because that would be eventually lead to suicide, for example. So they might only focus to adapt MDD module to their context. Maybe some region will only worry about conduct disorders because they worry about adolescents, criminal activities and everything else. So they would focus on how to adapt this and what kind are looking for other resources or instruments that they can use. There is nothing wrong, I guess. And because maybe we when we talk about a region that is worried about conduct disorder and we give them these 5 for their consideration and they read it and they said that no, this is too details, or I don't want to ask an adolescence about having sex, forcing somebody else to have sex, this will create havoc in my neighborhood, and we need to respect that. We cannot push them to do something. So okay, then
I think she lost the connections. Okay. Okay, should we move to the last questions? I know time is up, but we have one questions. Yeah, it's from Fadil and Bapak Fadil, and he says that he thinks that the problem is mostly due to the lack of awareness or knowledge about mental health issue. And would that be possible to include mental health as a part of the compulsory subjects at school? And maybe you may answer from the Australian perspective, and Dr. Amira may also answer from Indonesian perspective. Would it be possible to include mental health as one of the compulsory subjects? And is there any further discussions about this, including mental health in the curriculum, or maybe the Ministry of Health programs? I think Dr. Amira has mentioned something about it before. Yeah. Okay.
I guess just, from a public health perspective, having mental health education in schools, particularly early on, so talking about primary school, is, I think would be a really great step forward that any country that hasn't taken, could take as well. And it's not about, I guess, frightening children and talking about depression and anxiety, but again, it's just talking about health in terms of how you feel, both physically and mentally. So, how well does your body feel? How happy does your brain feel? You can really make it accessible to quite young children as well. And we know that if that just becomes part of the education, then that will just become normalized for them as well. And talking about feeling sad will be as, accepted as talking about, feeling sick or having a cold. So it's not to minimize the impact of mental disorders, but I think there are some really great opportunities to normalize them, noting that at the same time, it's important that we address awareness among parents and among, the older generation, ours included, so that, everybody, I guess, moves forward together. And again, the first step in this is getting the data to show everybody that, this is a health issue and this is present in the community. But most importantly, we can do something about it, and we can also take steps to prevent poor mental health as well.
Dr. Amira, do you want to add something? Oh, I think she lost.
Yeah. Can you hear me?
It's a bit hard to hear you.
Is it better now?
Oh, yes.
Okay, so yeah, I think like I mentioned before, right now we're still in the starting phase, like in the preparation phase to scale up the mental health education in 12 years mandatory education system. So our 12 years education system. And other than investing, so if we want to normalize mental health education at school, we need to invest. It means that we need to invest on our teachers, and also one resource that we haven't seen yet in schools is school nurses. So we should have somebody that can look for students well-being, including their mental health. Right now, the way that it's usually work in Indonesia is each school, each public school will be affiliated with puskesmas, with community health centers. So the doctors will come visit schools and do the screening. This is a good idea. So maybe we can just like modify it further. So instead of the doctors that only come like maybe every 3 months, maybe the nurses or the midwife can come every month, for example. So or more or a better communication between schools and puskesmas. So if the teachers that already trained, the teachers that have been trained in the mental health issues suspect something happens around the children, they can directly refer the children to the health providers. This is the system that it's currently take place in Magelang. So we have the national hospital, the National Mental Health Hospital in Magelang, and it affiliated with many schools around the hospital. So if the teachers, like suspect this student seems like having problem in managing, sometimes the teacher, like they are teachers, so they see that the student having problem concentrating, having problem in managing emotion, in saying what they feel, they can just refer the student in to the mental health hospital. This is a good system. So we hope that we can adopt it in many other places in Asia. So so we can really start not just screen, but managing mental disorders early and with a better coordination across sectors.
Thank you, Dr. Amila. Because time is up, so I would like to conclude briefly that adolescence is a critical period for mental health development, but awareness remains lacking within the adolescent itself and also the family and community. And there are very limited data available to measure the true burden, because such data will be needed to then make a future plan about preventive as well as the therapeutic measures for mental health disorder. And hopefully the INM's data will help to fill out the current knowledge gaps and help the stakeholder to future planning programs or interventions around mental health in Indonesia. I would like to invite the audience here to give applause for the two great speakers here. And before we close the sessions, we have photo sessions. Just everyone, please turn on your camera, and we will take some pictures to close these sessions. All right, I'll count on to 3. 1. Everyone ready? I'll just wait for a moment for everyone. All right. 1, 2, 3. One more time. 1, 2, 3. Okay, thank you everyone for joining this seminar. I believe that you are enjoying the discussions today, and I'll see you next time on the other seminar. Thank you.